Good evening, one and all. Thank you for joining this evening. I'm thrilled to welcome you all for today's informative webinar on an insight on puberty and disorders of sexual pubertal development. I'm Vijay, manager at Mediversal Academy, and I have the privilege of releasing our esteemed speaker for the day, Dr. Pujalakshmi B. Dr. Pujalakshmi is an obstetrician and gynecologist with over 7 years of experience in women's health, infertility, reproductive medicine, and aesthetic gynecology. She has trained at reputed institutions in India and abroad, including an advanced diploma in reproductive medicine from Yale, Germany. She has worked with leading hospitals such as Apollo Fertility, Cloud9, and MGM Healthcare. And she is currently practicing at Lakshmi Clinic, Annanagar, Chennai, offering both in-person telemedicine consultations. Her approach combines clinical expertise with compassionate care to support women across all stages of life. Over to you, Dr. Pujalakshmi.
Thank you for the introduction.
Thank you, Doctor. You have please share the screen.
Yeah.
Oh,
Can you see my screen now?
yes, Doctor. Yes, Doctor. Please share, open the PowerPoint.
Yeah. Is this fine?
Yes, Doctor. Yes, yes, it is fine. Just click on the I, Doctor.
Yeah.
Yeah, yeah. You can start now. Yeah.
Yeah. So very good evening. So the topic for today is puberty and disorders of pubertal development. So we are gonna go in depth about puberty. What are the stages which a child goes through in normal puberty, and the major two disorders that are found during this stage of development, and how it is going to be presented in the early adolescent child. So, sex differentiation occurs when the chromosomes start to develop. So, there are three different things when it comes to sex differentiation. One is genetic sex, where uh, the chromosomes determine whether the male or female child fetus is going to be developed. So that happens as early as 6 to 8 weeks within the womb of the mother, and this is going to in turn give rise to the anatomical sex, that is the development of the internal and the external genitalia. And as the child is coming into the world, and it starts to identify itself in a particular sex, this is a psychological aspect, that it sees its anatomical structure and starts to differentiate it as a male or a female. So, pertaining to this, if all the genetic, anatomical, sex, and the sexual identity are synchronized together, and all the stages happen as per the milestones of development, then there is normal puberty that is attained. But if there is some mismatch or there is some alterations happening, then there are pubertal disorders that occur. So, as I said, sexual development, this involves the development of gonads, production of hormones, and development of gender identity. So, the gonads are going to be developing within the fetus by 6 to 8 weeks of differentiation. And then, when they're going to attain puberty, the gonads are going to start producing the hormones. And as the child enters into adolescence, it starts to develop a gender identity of itself, differentiating whether it is female or male. So gender determination happens at the conception with XX chromosome, which is going to predict the outcome of a female child, whereas if it is XY, it is going to be a male child. So there is a terminology called disorder of sexual development, in short DSD, when there is a discrepancy between the genetic, that is the chromosomal, the gonadal, and the phenotypic sex. So there is a mismatch between the three different types of sexual differentiation. So earlier we used terms like ambiguous genitalia. Ambiguous genitalia meaning the external genitalia is still in the differentiating point where we are unable to point out whether it is a female genitalia or a male genitalia. And there are many conditions of intersex where true or pseudo hermaphroditism is also present in the child. So sexual development meaning they both the internal and external genitalia develop as per the chromosomal origin. So XX is going to produce the female, and XY is going to produce the male external genitalia. So today our focus is on a sector of those sexual disorders which pertain to the age group of puberty, that is starting from 8 years onwards in mostly in the female child. And what are the major disorders pertaining to puberty and menstruation that occur in the female child. So, how do we define puberty? Puberty is a period of significant growth and profound hormonal changes. So, yes, at birth and at differentiation, they are going to produce gonads and they're going to differentiate the external and internal genitalia. But this is the time, the puberty is the time when these gonads start to function, that is their hormonal output starts to begin at this age. And this in turn is going to produce more change bodily changes which are going to then make the female reproductive system functional for fertility to reproduce. That is the main feature of puberty. So from a child to an adolescent to an adult, that happens, and the main changes that occur during puberty promote this change to occur. So there are mainly two disorders that occur during puberty. One is precocious, that is earlier than before, or delayed puberty, may be present in the young child. So precocious meaning if an Indian average of attaining puberty is between 9 to 11 years, and if a child of 6 years attains puberty, then we can call it precocious. And delayed meaning if it is a adolescent of 15 to 16 years and they haven't developed any sign of puberty till that age, not even the remaining secondary sexual characters or even the attainment of menarche, then we can term it as delayed puberty. So these are the two main problems that we face during the pubertal phase in a girl child. So normal pubertal development occurs in an ordered sequence. So it is a very particular order in each and every girl child that it occurs. And this mainly
Hmm?
occurs by the, yes,
Sorry, this silently.
sorry, yeah, tell me. May know who's talking like. Can I access the Zoom? Yes. Yes, somebody was talking. Is there any question? You can type in, I think, in the chat box so that we can address your question as well. Is that okay? Okay, by mistake, fine. Okay, we'll continue this. So, in every normal girl child, we see a series of changes that occur. So, there is a time and there is an order with which puberty occurs, and any slight mismatch in that also needs to be investigated and taken care of, because it is again a girl child we are talking about. We don't want any later disruption of the reproductive system or any ailments or pathologies in the reproductive system to occur when they are entering early adulthood. So, along with these secondary sexual characteristics, there is a rapid increase in growth that culminates in the reproductive capability. So, puberty doesn't mean only the secondary sexual characters. You can see a increase in their stature, in their body height, and the width of their body. All these linear growth changes also occur during puberty, and again that is also under not only the influence of the estrogen progesterone hormones, it is also the growth hormone that plays a major role for this pubertal changes to occur. So, we are all aware about the hypothalamo pituitary ovarian axis. So, what is the role and how does this initiate puberty? So, as the girl child uh, is born, there is development of the ovarian gonads occurring, but its function of producing hormones starts only at puberty. So, uh, when there is a trigger that the girl is reaching 8 to 9 years of age, there is gonadotropin releasing hormone which is released in a pulsatile manner from the hypothalamus. So this pulsatile release of GnRH is then going to stimulate the pituitary. So again, pituitary is again stimulated to secrete FSH and LH. So this in turn is going to stimulate the ovary, and the ovary is going to produce two hormones, estradiol and androstenedione, so which in turn are going to get converted to estrogen and progesterone, and this estrogen and progesterone is going to act on the uh, reproductive organs, the external genitalia, the internal genitalia, and the other secondary sexual characters being developed through the action of these hormones at localized regions. And this is going to trigger the various stages of the menstrual cycle as well. So the initiation phase and the initial 1 or 2 years of menstruation also starts along with puberty. So this is the HPO axis for you, the hypothalamus being releasing GnRH in a pulsatile manner. It is going and stimulating the pituitary, which is releasing LH and FSH, which is in turn acting on the ovaries to produce estrogen and progesterone. and it is a positive feedback mechanism, as we all have studied in physiology. It is a positive feedback mechanism that keeps on triggering the hypothalamus to do this cycle after cycle, so that estrogen and progesterone is produced in a monthly manner in, the two phases of the menstrual cycle. So they are adapted to those two phases, and this occurs cycle after cycle, so that by 8 to 10 years they start developing all the pubertal changes, and at least by 10-11 years all their secondary sexual characters have reached the final stages of development, and their menstrual cycles are set right by at this point of time. So what are the changes that we see in the normal adolescent girl child? So I told you already that there is an amplitude of growth hormone that's also secreting in the pituitary, along with FSH and LH. So this growth hormone is going to act side by side with estrogen and progesterone. So accelerated linear growth is one that we see, which is because of growth hormone. The remaining things like development of breasts, thelarchy, axillary and pubic hair development, adrenarche, and the eventual onset of menses, that is menarche, are all dependent on this HPO axis. So, generally, in a normal adolescent girl child, these stages occur, and they occur in a timed manner. As I told you, there are many timings for these to occur, one after the other. There is a sequence, and sometimes I told you that if there are some discrepancy like premature thelarchy or adrenarchy, which occur little before the normal limits, then that is to be addressed to. And these generally occurs because of three main things: can be the race of the individual, can be a family history, or can be a nutritional deficiency that can indirectly influence these changes to occur even prior to the uh, a known milestone. So recently, there is a study that has suggested that the age of puberty is declining, possibly triggered by the increasing rates of obesity. So obesity again is going to create a lot of problems with growth hormone and the HPO axis, and there is early onset of all these things because there is early initiation of the HPO axis and GnRH pulsatile release occurring in little obese children. So there is a increase in number of early onset of puberty or precocious puberty that is seen. So this is roughly what is the changes that we can expect in a girl child between average 8 to 11.5 years. There are breast changes and there is pubic hair changes that are occurring. We will be seeing in detail what are the changes pertaining to each arche, menarche, pubarche, and the axillary uh, hair development and the pubic hair development. So the three main changes: thelarchy, adrenarchy, and menarchy. So thelarchy is nothing but the breast tissue development that begins as a subareolar breast bud. The initial sprout of breast, we call it as breast bud, and this is because of unopposed estradiol. So we are all aware by now that GnRH is going to trigger the ovary to continuously produce estrogen. Estrogen is gonna go and act continuously on the breast tissue, the child's breast tissue, to produce a breast bud. So it begins, puberty mainly begins with thelarchy in 80% of the girls, but 20% again can experience adrenarchy first, which is not pathological. So mostly it is thelarchy for the majority of the age group, but 20% can start with adrenarchy and doesn't have to be any particular pathology. So, what is adrenarche? Adrenarche is the normal onset of adrenal androgen production that occurs 1 to 2 years before puberty. So we have the breast bud formation and then the adrenal androgen production. So that is again important for the hormones to go and act on the localized tissues to produce sex steroids. So it is independent of the maturation of the gonad. So this is again dependent on the adrenal androgens, and those are going to produce few more changes where body hair develops in the child, pubic hair starts to develop. All these things are dependent on the adrenal hormone uh, secretion. And the most important of them all is menarche, which is the menstrual cycle initiation. So reproductive maturity occurs with the onset of menstruation. So we saw previously that before puberty occurs, we have adrenarche. So the first is the breast bud formation, followed by the adrenal hormone secretion, then followed by menstruation, and it can include the pubertal changes as well. So, menarche usually occurs after the peak in growth velocity. So, meanwhile, with all these changes occurring, there is a growth hormone increase also seen in the child. So, which is going to produce a linear growth along with the acquiring of all the secondary sexual characters meanwhile. So, as I told you earlier, the first 2 years of post menarche, the menstrual cycle is kind of erratic. It is still not very regularized, very set right, and still the HPO axis is trying to figure out when to produce the cycle and trying to set right into the 28-day regular cycles. So, initially, if a patient comes to the OPD with a girl child who's like 11 years, 12 years, and they just have attained menarche like 1 year ago. And she just keeps complaining it is irregular. She just gets periods for 1 day. There is no flow in the cycle. The best thing that a doctor, a gynec can do is reassurance. So, initial 6 to 18 months, the ovulation is trying to set right, the hormones are trying to set right the date of menstrual cycle, trying to set right the regularity of menstrual cycle into 28 days. So there need not worry that initial 1 to 2 years of the menstrual cycle is irregular or there is less flow, or it is not, it is occurring with a lot of date variations. These things are taking its due course of time to set it right, because the maturation of the HPO axis differs from person to person. And again, the growth spurt. So there is acceleration in the rate of growth, which can accompany the pubertal development, or it can even occur preceding to the pubertal development. So there is linear increase in height, increase in shoulder width, increase in trunk length. All these changes are because of the growth hormone, and the growth spurt generally begins between 9 to 14.5 years of age, and it is dependent on the growth hormone and indirectly by the gonadal steroids as well. So a small portion by estrogen and progesterone and major portion by growth hormone. So in the girl child, we'll first see the lengthening of legs, followed by increase in shoulder breadth and increase in trunk length. So they are transitioning from a child to an adolescent, and the visible difference for us from outside is the linear increase in growth. So another very important change that we find in the gynecological aspect is the pelvis enlarges. So it is getting ready for the reproduction function, and the shape also becomes into the adult gynecoid or pelvis, the type of pelvis that genetically she has acquired. And most girls reach the maximum growth velocity by 2 years after thelarchy, and 1 year prior to menarche. So before initiation of menstruation, actually all these growth spurt changes will have completed. So maximal height is reached between 17 to 18 years of age with fusion of femoral epiphysis. We usually say, right, by 18 years, the all the epiphyses of the bones are fused. So even that is pertaining to this as well, where 17 to 18 years of age, all this growth spurt kind of tends to come to an end, and the actual height of the individual, which is the adult height, will be reached by 17 to 18 years of age. So as a child who's transitioning into puberty, these small changes are noticeable by the girl itself, and they might tell it to their mother, and it can reflect as some pathology, and they might come to the OPD. There are hair growths in the axilla, in the pubic region, the already existing bodily hair becoming more denser. There is a height development. There are pimples or acne developing on the face. There is breast budding, and there is initiation of periods. So our duty as a doctor are to say that these are the right things happening at the right age, and there is no need to worry, and the you just need to note the changes that are occurring, and if they find any difficulty, it is just a matter of reassurance that all these changes are normal in this phase, and there is nothing need to be addressed to, and nothing pathological that is happening to them. So that is one thing. So we have seen enough about the puberty, the stages, about telarchy, adrenarchy, the growth spurt, the menarche, and the other changes that occur. Now, as I mentioned earlier, if there are any small changes that are noticed and that are alarming to the mother or the child, then it needs to be addressed. And the main anomaly of gonadal dysfunction is delayed puberty, so which is a worrisome factor for the entire family, because they just feel they will miss a chance of getting pregnant in the future. So initiation of puberty and initiation of menstruation is a very important milestone in the family for a girl child. So delayed puberty is defined as when the secondary sexual characters do not appear by the age of 14 years, and menarche is not established by 16 years of age. So we can otherwise term that as primary amenorrhea, never having the periods, not even a single episode till 16 years of age, and no development of secondary sexual characters, no pubic axillary hair, no growth spurt, none of these occurring by 14 years of age, then it is considered to be delayed puberty. So this can also be because of the gonadal causes, whereas there is a slight gonadal dysfunction, that is, it is hypogonadism, and it can also present in cases where the gonadal function is still okay. There might be a hypothalamic or hypo pituitary uh, discrepancy that is causing it. So, as I told you, eugenodals occur with the evidence of steroidogenesis, but there is delayed menarche, hypogonadism, failure of maturation of the hypothalamic pituitary ovarian axis, and the ovaries are not able to perform its function of producing the estrogen progesterone hormone. So that could be the main uh, reason why the initiation itself has not occurred. When the HPO axis is not being stimulated by gonadotropins, then there is no production of hormones, which in turn will not produce any of these secondary sexual characters or initiation of the menstruation. So again, if it is because of the local causes of the ovaries, there is some ovarian pathology. There is hypogonadism where the ovarian function itself is hindered, or there are some streak ovaries in case of disorders like Turner's, where the ovary itself are very small in size and they're unable to produce the sex steroid hormones. Then that itself can be another reason why there is no initiation of pubertal changes occurring. So another anatomical defect which can uh, be set right is the Mullerian developmental anomalies, where there are discrepancies of the uterus, the vagina, the cervix, and the outflow tract is obstructed. So they might still be producing the hormones, the HPO axis might still be functional, but there is an outflow obstruction to the menstruation. So this is a very easy diagnosis where we just do an ultrasound. If we note there is some bicornate or unicornate uterus, or there is hematocolpos where there is blood within and it is not able to come out because just there is an outflow obstruction in the vaginal tract, that is a very anatomical defect that needs to be corrected and investigated. And there is the other group of disorders that are the sexual dysfunctions, which are testicular feminization, androgen insensitivity syndromes, which are a very smaller reason why these changes do not occur, because the problems in those are much complex, and there is a genetic and chromosomal mismatch that is also happening in those disorders. A small group of which will still present with delayed puberty. So, what is the reason, or what are the reasons that can lead to delayed puberty? So, most commonly, it is of familial origin. So, if they are their mother had the similar issue that she didn't attain puberty by 14 years, or she didn't get her periods by 16 years, then that similar familial origin might occur to the female girl child also. As Kalman syndrome, where there is hypothalamic pituitary inadequacy, meaning they are not able to function and produce good amounts of GnRH and FSH-LH, which in turn is not going to be enough to act on the ovaries. And local causes, that is ovarian causes, are things like Turner syndrome, Swyer syndrome, testicular feminization, autoimmune diseases, that in turn have like very less functioning ovaries, and they are in turn not able to produce the required amount of estrogen and progesterone to set right this pubertal cycle at the right age. And again, polycystic ovarian disease, where there is a lot of hormonal mismatch. There is a mismatch of FSH-LH secretion. There are lot of multiple follicles in the ovaries, but they're not able to produce the amount of estrogen and progesterone required for menstruation and ovulation, especially to occur in polycystic ovarian disease, because it is an anovulatory amenorrhea that is also, or oligomenorrhea that is occurring in polycystic ovarian disease. And for that matter, if there is an absent uterus itself, so there is a total major congenital anomaly being hidden, and it has never been evaluated, and it comes to light only when we investigate for this delayed puberty. And there is cryptomenorrhea occurring along with it or separately. And as I said, if there is a Mullerian anomaly, if there are didelphys uterus, unicornate, bicornate uteruses, two vaginas, there is obstruction in the outflow tract, cervix is anatomically defective, then even if the HPO axis is functioning and menstruation cycle is initiated, the menstruation does not occur, and there is primary amenorrhea because of obstruction in the lower genital tract. And the other very psychosocial cause that causes this delayed puberty is there is a big taboo in the younger age group girls to remain lean, to be accepted by their peers, which leads to the self inflicted malnutrition, cutting down their intake, leading to anorexia like disorders, which will directly attack the pituitary, and is not going to be able to function to its fullest. And another endocrine disorder, which is hypothyroidism, also can delay the pubertal and menstrual changes that has to occur. So, if a girl who is around 14 to 15 years with no secondary sexual character development coming to your OPD, and you just ask them to wait for another 6 months to see if there is any change or initiation of menstruation, uh, and then they turn up with no such development, then you start to evaluate the girl. So we take in a detailed history, like as I mentioned, if there was any malnutrition from her side, trying to cut calories, trying to have an anorexic way of being having an appetite like that, or if there was any episode where she had any secondary sexual characters developing. And physically, when we examine, we record the height in centimeters. As I said, if she's coming like at 14 or 15, we can measure the height and weight, and later after 6 months to compare with if she had still had a bad uh, diet history and malnutrition history, if there is a decline in weight, uh, and if there is no increase in height. These are the easy points that we can assess and come to a provisional diagnosis uh, just by history and examination. So, to further evaluate, we see if the hormones are of normal values by measuring serum FSH, LH, prolactin, and TSH, and if needed, the androgens also. And another reason why we do the CT scan of the skull is to see at least if the growth hormone has initiated its uh, action, and if there are other adolescent changes seen in the skull, if there is any bone age that can be detected through the scan of the skull, is an investigation that we can still wait and do, but it is a very important investigation. And buccal smear is for sex chromatin determination to see if actually chromosomally she is XX female and there is no discrepancy to it. And G banding to see if she is having any Turner syndrome or Swyer syndrome or any other genetic factors that could have led to this delayed pubertal change. And another very, very, very OPD important investigation is ultrasound of the pelvis. A trans abdominal ultrasound is enough to detect if there is actual good healthy ovaries developing, or their ovarian volume and sizes are very small or streaked, and to detect uterus being present, and if there are any anomalies like the Mullerian defects as I mentioned earlier. And if these are all giving us a very vague idea, to do a really confirmatory identification and investigation, we can go ahead and do a laparoscopy to see a detailed examination of the internal genital system of the developing female. So, what are the more specific evaluation points in the history that we can ask is ask for growth charts as a child, if she had attained her milestones, if she had all the length, weight, and other factors have reached the milestones at the right time. The growth charts as a pediatric patient if she had attained all the milestones at the right time. And the height and weight records, as I mentioned how earlier, we can even evaluate on a 6 monthly basis. And if she had any previous school records, if she has uh, increased or decreased in weight, all these things should be noted. And the chronology of development, if she had maybe one sexual character developing, uh, what is the order with which she has developed, or if there is some mismatch in the sequence of events that has occurred. And the body habitus, if there has been only widening of the shoulders, or if there has been only increase in height, or if she is very athletic, some bodily habital changes that has seen. And very important to know at this age group of this age of time, any administration of drugs, and if she had any illness such as TB, thyroid disease, or juvenile diabetes, or mumps, and as a result of which they would have been on any uh, hormonal supplement, or they had been on steroid administration, and has that caused any hindrance in the attainment of puberty. And the specific examination that we can do is maintain a height to weight ratio chart, and the stature and body type, as I mentioned, if it is obese, or if it is undernourished, or if it is athletic, that can also give us a clue. And the Tanner evaluation for maturation of status, I put up a box showing the axillary, pubic, and the breast bud development, which is termed as the Tanner stages of secondary sexual characteristics development. And other than which, we can check for any genetic or endocrine causes behind this. So this is the Tanner stages of secondary sexual development. So pre-pubertal, that is, a child will not have any sort of elevation in the chest region, and there is no pre-pubertal hair in the pubic region. But once the pubertal changes start, you can see a slight breast bud being present in the chest region, and there is pre-sexual very fine hair developing, which then goes up to elevation and the formation of the nipple areolar complex. And there is coarse thick hair that is starting to develop in the pubic region. And now there is a separation between the breast tissue, and there is a separate areolar mound that is happening, and the nipple areolar complex is trying to project itself from the breast tissue. And the uh, pubic hair becomes like an inverted triangular shape, and it is becoming more pigmented. And finally, they reach the adult contour of the breast, and the triangular inverted triangular pubic hair, which is thick, coarse, dense, and very pigmented. So these are the main changes that we look for in a adolescent female who undergoes a natural changes in the pubertal development of secondary sexual characters. So this gives us a picture whether each of the stage is attained by the child. If there is nothing happening, then we can assume that there is a delay in puberty. So these are how the axillary hair develop in the young female. So initially there is no development, and there is few sparse hair, then there is a pattern, and then there is a thick, coarse, and pigmented hair that is present. So we have investigated the girl child, and now based on which what can we arrive at with these investigations. So as I mentioned, USG pelvis is the most important investigation to see if there is a functioning uterus and vagina that is present, and the serum FSH levels are going to help us tell if it is a CNS cause, if there is a pituitary cause, and it is going to differentiate between pituitary not functioning and the ovary not functioning. So FSH levels are very very crucial too. And as I mentioned, we can do a skull CT skull X-ray or a skull X-ray, either one, based on the need and the severity of the issue, to assess the bone age. If at least radiologically they have attained the bone age of a 15-16-year-old, then at least one of the hormones is still functioning, the growth hormone. But if there is excessive growth of the skull and there is still no initiation of these cycles, then there is a diagnosis of exclusion, which is pituitary macroadenoma, which needs to be evaluated separately before going ahead with evaluating delayed puberty. And as I mentioned, genetic karyotyping is very very important to see that she is an XX chromosome female and not of any other karyotype or any genetic disorder that she is presenting with, which shouldn't be missed at this point. And FSH levels, as I mentioned, if it is more than 40, then we need to evaluate further the hormones, where we are going ahead with androgen estimation and um see to that the values correlate with the FSH values. So, little bit of detail about the Tanner classification of sequence of development. So, as I mentioned, the thelarchy, which is the breast bud development, is the first change that we see between 9 to 11 years of age. So, it shows us the competency of the HPO axis, and the adolescent breast development is divided into 5 stages. So, as I showed you the picture earlier, there are 5 stages of thelarchy: B1, B2, B3, B4, and B5. So, the pre-pubertal breast, where only the papilla is elevated, is the B1 stage. And B2 denotes the breast buds are palpable and the breast elevation occurs and the areola enlarges. And B3, where there is further enlargement of the breast and areola, but there is no separation of contours. There acts as a single complex. Then by B4, the areola nipple leads into a secondary mound. They become a separate complex, a nipple areolar complex, and there is a mound on mound, that is the nipple areolar mound on the breast mound, that separates out at B4. And B5, there is formation of the mature adult breast, and the general contour of the breast becomes fuller. The breast becomes fuller and reaches the adult breast size. So, adrenarche is again the production of the adrenal androgens, which are in turn going to give us the growth and development of the pubic and axillary hair, right, which I mentioned earlier. Pubic hair generally appears 6 months after thelarchy at the B4 stage. So, this is a sequence that we can remember. So breast budding happens 1, 2, 3, B4 stage, and at B4 stage we might see the thick coarse hair developing at the pubic region. And axillary hair generally makes their appearance 1 to 2 years after puberty. So we can wait further for the axillary hair to about 1 to 2 years after the pubic hair develops. So rarely axillary hair development precedes pubic hair. It is mostly breast bud, pubic hair, then axillary hair. So pubic hair development also occurs in 5 stages, as I showed you in the picture. So pre-pubertal, no coarse pubic hair, just vellus hairs. P2, there is pubarchy with long curved pigmented hairs which are spread over the labia. And uh, P3, where are dark, coarse, and curly hair develops over the mons pubis. And P4, there is pre-adult stage when there is thick, dark growths of curly hair seen covering the short inverted triangle. And P5, the adult inverted triangular shape with thick, coarse, dark, curly hair spreading out and towards the medial aspects of the thigh. So, which particular hormone is dihydroepiandrosterone, uh, which is a byproduct of the androgens, and that is very particular for the pubic hair development. So, axillary hair development, which follows pubic hair development, has 3 stages. Uh, so, the first stage is where there is no hair, and then pre-pubertal stage, and then there is sparse axillary hair, then the adult distribution of thick, coarse, dark pigmented hair. So, these are all the secondary sexual characters, but the main sexual reproductive system, what does that undergo at this point? So we're going to see about the vulva, vagina, the uterus, and the ovaries. What changes from the prepubertal stage to the puberty? What changes they undergo under the influence of the functioning hormones? So vulva skin under the influence of estrogen becomes keratinized. It becomes pigmented. It becomes thicker, and is resistant to infection. And labia becomes a little more plumper because the fat is deposited in the labia majora. And vaginal mucosa becomes multi-layered, so which is very thin, becomes multi-layered. And there is the induction of the Dodelins bacilli, which maintains the pH of the vagina at 4.5. And this is bacilli is acting upon the glycogen produced by the vaginal mucosa to maintain that pH. And uterus, initially the uterus to cervix, there is a equal proportion of uterus and cervix that is seen, which is 1:1. And under the influence of these hormones, the body and the fundus grows and it becomes larger than the cervix, so it can reach up to 2:1 or even 3:1 ratio of the uterus is to cervix, from the initial prepubertal or the child size of the internal genital organs. And ovaries become larger, their volumes increase, and they start producing primordial follicles which can develop into Graafian follicles. So about menarche, usually follows thelarchy by about 2 years. So breast budding happens, pubarchy happens, axillary hair development, and within that time, 2 years gets completed, and there might be an initiation of menstruation that happens. And at this stage, there is complete breast development, and it reaches the adult mature stage. That is one clear indication that the puberty changes has happened in its sequence, and thelarchy has been completed by this point. And the initial menstrual cycles, as I told you earlier, 6 to 18 months, since they are trying to figure the ovulation and trying to set right the menstrual cycle into 28-day cycles, they are generally anovulatory about 1 year to 1.5 years. And that is why it is irregular, and there is no pain as well because there is no ovulation occurring. So there is no pain or cramping during the cycles or during the ovulation as well. So skeletal age, again, we need to see if the bone age and the chronological age are correlating. So it is a good marker to see if there is potential for growth occurring, and if the growth has occurred at this point, and to also determine the final adult height. This indicates if there is a linear growth that is happening. So at this point, if there is delayed puberty, you know that the mother and the father and the child are under a lot of psychological and emotional stress, which needs to be reassured and given a clarity that this needs to be investigated, and there is treatment for delayed puberty, and they need not worry about it, and they have come at the right time. So again, if it has been inflicted by the child, that she has not had proper nutrition, had some episode of anorexia, trying to match with the peers, then proper nutritional guidance about the various food groups, about what needs to be increased in amount for their growth and development needs to be given. And we're going to treat the cause following the investigations and the diagnosis. So usually we tend to find a cause, maybe familial or maybe chromosomal, can be a disorder of sexual development, or can be a outflow tract obstruction, a Mullerian anomaly. We can pinpoint the reason behind it. But if at all it is idiopathic, there is no cause at all, then it is much more simpler, because we are just going to do the work of the HPO axis. We are just going to provide estrogen and progesterone to initiate menstruation and start the development of the secondary sexual characters. At least by that age, if it starts at least by 18, 19, 20, she is still having all the secondary sexual development, initiation of menstruation, adult height, by the help of external estrogen and progesterone therapy. So most of these cases of delayed pubertal development respond well to hormonal therapy, and there is a question if there is any harm later in her reproductive years, but there are no severe side effects for future reproduction with hormonal replacement. So, how do we address this induction and replacement of hormones in adolescent girls? So, they will require a very short protocol of sex steroid replacement, so that their growth catches up with their peers. So, if they have uh, peers who are 15, 16, and they've already attained all the milestones of thelarchy, pubarchy, height, and axillary hair, and they are still 16 with no changes. um, at least if we start at 16, at least by 18, 19, they catch up with their peers and they don't feel missed out. So there are various forms of estrogen and progesterone that are used for the induction. So mostly the exogenous induction with estrogen will achieve again all the milestones in a timely manner. That is the beauty of using exogenous estrogen, where it beautifully again starts with telarchy, starts with then goes ahead with the changes in the timely manner, and reaches menarche by 1 or 2 years. So that is the beauty how exogenous estrogen also works. So it is mostly low dose estrogen that we give, that can start at the age of 10 years. But that again, in our scenario, is too early, where we don't expect a 10-year-old child to be starting to develop all the secondary sexual characters. We can still wait, but it is by the books, by the journals, it is still okay to start by the age of 10. And in this situation, 2 to 3 years of unopposed estrogen could be achieved before progesterone is introduced to trigger the first withdrawal of bleeding by the age of 13. So, in case we are starting estrogen by 10 years, then 2 to 3 years, we are just going to give only estrogen, because this unopposed estrogen is required before we start progesterone. Only when we give these unopposed estrogen, then On introducing progesterone, it will trigger the menarche to occur by 13 years. There is no role of having oral contraceptive pills where both the hormones are acting on the same time. So, the protocol of management of delayed puberty is induction of exogenous estrogen therapy for a period of 2 to 3 years, followed by progesterone, which will in turn trigger the menstrual cycle to occur. And by the 2 to 3 years of unopposed estrogen, all the secondary sexual characteristics are initiated, and they will reach the level of attainment by the initiation of menstruation. So even if we are starting unopposed estrogen therapy by 15 years or 16 years, then we need not wait around 2 to 3 years to start progesterone. A 6 to 12-month course of estrogen exogenously is enough, after which we can start introducing progesterone. So the main indication for usage of sex steroid replacement is constitutional delay of puberty. The other indications are gonadal dysgenesis, premature ovarian insufficiency, hypopituitarism, hypothalamic amenorrhea, hypogonadotrophic hypogonadism, and other disorders of sexual development. So most of these situations where the hypothalamo-pituitary ovarian axis has not attained maturity, the initial pulsatile GnRH trigger has not occurred. So there is no free flow of hormones. There is no production of sex steroids. So exogenously, we are replacing the sex steroids in a pulsatile manner for a longer duration, and then slowly introducing a secondary hormone to initiate the changes that need to be happening by this age group. So most of the regimens till 10 years to 12 years, if we don't see any changes, I still think people will not come to the OPD and say they have not developed a breast, but they have not developed pubic hair. They're still going to wait till 14, 15 years, and they might feel starting hormonal treatment at such an early age is going to create more harm to the child than good. But still, it is advisable to start by 10 to 12 years also. It is recommended. And ethinyl estradiol is a commonly used estrogen. Route of administration being oral, or there are these transdermal matrix patches. So that is, I think, a preferred route of administration, because these kids are not really going to be keen on having tablets. They might as well have a patch stuck to them and as well forget about it, which is going to release in due course of time the amount of hormone needed for them. And the most common progesterone that is used is norethistron, and progesterone, which is used post estrogen therapy, is the main reason to uh, promote the withdrawal bleeding. So, as I mentioned earlier, these combined oral contraceptive pills we use left, right, and center in gynec are of no use in delayed puberty, because they are unphysiological. They do not provide the optimal estrogen replacement in young women requiring the initiation of puberty. So, we are just mimicking the similar pattern that is happening in a normal child by giving unopposed estrogen initially and then introducing progesterone. So uh, we see the changes of these secondary sexual characters, which are naturally presented by estrogen in the body. And then when they attain menarche, there is action of progesterone. Similarly, we manage by giving progesterone after 2 to 3 years to mimic what is physiologically happening in the girl child normally. So we are just helping realign the same hormonal mode of action. So these transdermal estradiol patches, the dose starts from 6.25 micrograms in younger age group to 12.5 micrograms in older age groups. So the timing and dose escalation should be individualized, taking into account the potential of further growth. So we start with a low dose and we see the changes that occur. We see if all the uh, stages of the tanners are achieved, and taper or increase the dose depending upon the uh, outcome that is seen out of the hormonal replacement. So the dose of estrogen then is increased until breakthrough bleeding occurs. So mostly we step up the regimen, start with the low dose and step up, and then as we expect the breakthrough bleeding, we start with cyclical progesterone therapy. So we have completed one major pathology, that is the delayed puberty. How the stages of normal puberty are not attained till the age of 14 years, no secondary sexual characters until 16 years, no menarche. What are the history examination findings, what investigations we'll do, how to interpret the investigations, what hormonal replacement therapy we'll do, how many years of hormone replacement therapy is needed, how to withdraw to initiate menstruation, and how to step up the regimen for the uh, hormone replacement therapy, which can mimic the internal failure of production of sex steroid hormones. So the contrary to delayed puberty is precocious puberty, where there's appearance of secondary sexual characters before the age of 8 years, which is of more alarming concern, and the occurrence of menarche before the age of 10 years. Both the parent and the child are not able to cope up with these changes because their peers are still smaller, they still don't have any breast buds, they still don't have any growth spurts, but these kids will look like a kid with secondary sexual characters and not matching with the peers of the same age group. It is not very common uh, compared to delayed puberty, which is now commonly occurring. Precocious puberty was not common for a long time, but now with rising cases of obesity happening, childhood obesity, this is also increasing in numbers, and the scenario has shifted to being equal numbers of delayed and precocious puberty being handled by gynec doctors. So there are three major groups of precocious puberty: true precocious puberty, incomplete precocious puberty, and pseudo precocious puberty. So, what is true or complete precocious puberty is when there is premature maturation of the hypothalamic pituitary axis. So, it is totally contradicting to delayed puberty. Delayed puberty, there is no maturation of HPO axis. Here, there is very premature initiation of HPO axis, and GnRH starts to stimulate the pituitary at a very young age. So, this is what is called as true precocious puberty. So, again, the causes can be because of genetic constitution, causes congenital lesions of the hypothalamus or pituitary, acquired infection, trauma, or neoplasm of the CNS. It can be a part of a small syndrome like McCune-Albright syndrome, neurofibromatosis, or other endocrine disorders. So, one very usual cause is a neoplasm of the pituitary, which in turn is hyperreactive, and it is triggering the HPO axis earlier, and it is constantly being triggered, and the baby develops the secondary sexual characters in a rapid manner, and one MRI of the skull is going to give us the diagnosis. So another variant of precocious puberty is incomplete precocious puberty, where there is only one secondary sexual character that occurs prematurely. Either there is premature thelarchy, there is premature breast budding, or there is premature production of pubic or axillary hair, or there's premature menstrual cycle initiation. So this is incomplete because it is not all the characters that are occurring together, but individually there might be one sexual secondary sexual character that initially turns out. The other variant is pseudo precocious puberty. There are elevated levels of estrogen and other hormones because of ovarian adrenal tumors, or the intake of hormonal tablets can result in pseudo precocious puberty. So, as I mentioned, the true variant can have a CNS tumor, but in pseudo precocious puberty, it can be an ovarian tumor, which is producing excessive estrogen and progesterone, or an adrenal tumor, which is producing other steroids. And in case there was some hormone replacement therapy, this could have initiated the uh, puberty changes earlier than normal. So there is association of vaginal bleeding occurring in very young age group like 5 years and 6 years, but it doesn't happen as a cycle. There is no cyclical bleeding that is happening. It can be one or two individualized episode that is happening. So, as I mentioned, the causes can be feminizing ovarian tumors, adrenal neoplasms, hypothyroidism, and any external hormonal administration that had occurred. So the reason being, most of the cases, the HPO axis or the adrenal functions or the ovarian function of producing hormones occur early, resulting in precocious puberty, which is pseudo precocious puberty. So, contradicting to the other child here, the child will have faster sequence of events of sexual maturation from the normal standard pattern. There will be like clubbing of all the Tanner stagings, and there is so much of development within 6 months to 8 months. They developed adult size breasts, they developed inverted triangular pubic hair, they might develop adult level of axillary hair, sudden growth spurt, increase in height, increase in trunk length, leg length, all these things. So growth spurt occurs at an early age, and eventually there is a stunting of height. So what happens is there's a sudden maturation of the HPO axis. There's a sudden surge of hormones. It happens at a very early age, and then it stops at a point. So they are like stunted with secondary sexual characters. So they might also not be mature intellectually or emotionally at this point. They are still a child with the secondary sexual characters. They just appear little mature and have these characters, but they behave and they are psychologically still a younger child of 9 or 10 years old or even earlier. So menstruation sets in early, independent of the customary sequence of thelarchy, adrenarchy preceding the menarche, and eventually fertility remains unimpaired and the adult height is attained. So later, what happens is, as I told you, there is a clubbing of the sequence of events that is happening. So there is no particular order with which everything is happening, and the menarche might occur prior to the adrenarche and the thelarchy, but at the end of which, though all these things are occurring prior to the required age group, the hormones are still functioning in the manner they should be functioning. So at after a certain point, they're reaching their adult height, and their uh, external and internal genitalia are fully functional. So there is no impairment in fertility or reproduction that is going to happen in the future. So again, how do we investigate this child? Okay, rapidly she is developing so many characters. So the growth measurements are of again real great value in assessing how fast she's growing. So again, X-ray of the wrists to establish the bone age, a fusion of epiphyses, if there is any earlier attaining of fusion of epiphyses, thyroid function test to see if any hypothyroidism or hyperthyroidism is present, and doing a EEG or MRI of the skull to see if there is any pituitary neoplasm or any abnormality present in the HPO, the hypothalamo pituitary region of the HPO axis, an adrenal function test to see the cortisol hormones and the adrenal steroid hormones that are being overly stimulated, overproduced, and pelvic ultrasound to see correlate if the sex steroids that are produced are producing changes in the ovaries, changes in the uterus, changes in the female genital tract that are occurring, and GnRH stimulation test to see if the GnRH that is being produced is excessive in amount, or it is initiated very prematurely, and also to note down the FSH, LH, and estrogen levels if it is correlating with the chronological age. So, how do we manage the treatment for this precocious puberty? Is we give an injection of depo medroxyprogesterone acetate DMPA 100 to 200 grams every 4 weeks. So DMPA acts by suppressing the HPO axis, suppressing the adrenal cortical hormones. So at least to some extent suppress the action of these hormones happening in a rapid manner, and stop the rapid sequence of production of the secondary sexual characters. So it is given either fortnightly 2 weeks or once in 4 weeks. The other drug is cyproterone acetate, which has an anti-androgenic and anti-gonadotropin effect, dosage being 70 to 150 milligram per meter square per day. And there is another GnRH agonist. So when we are going to give an agonist, we are trying to suppress the internal GnRH secretion, which is gusrelin, which is the mainstay of treatment for precocious puberty, which is used by a nasal spray. So 100 micrograms given daily. So that is the mainstay of treatment, because children are more compliant to this than injections and drugs. So nasal spray daily shouldn't be a issue with the child. So again, though we are giving so many drugs to suppress the hormonal system, this does not affect the future reproductive capacity of these cases, and there is no premature menopause since they attained all these stages early. That doesn't mean they're going to attain menopause by 35 or 40. They're still going to have their uh, reproductive capacity and reproductive level of hormones till they attain menopause. So, if there are cases of adrenal hyperplasia or ovarian tumors or neurological origin tumors, as I mentioned, like pituitary tumors or CNS tumors, surgical intervention is needed, and post surgically they must be monitored carefully if there is no recurrence of tumors, and they are not creating a hormonal disruption again. So some images of the normal prepubertal and how the changes occur to the adult size. So the generally we use the abdomen probe transducer to do an ultrasound of the pelvis to see if anatomically we are seeing a ovary, we are seeing a uterus, and we are seeing them develop with due course of time. So this is the primary modality which we use to investigate, at least if anatomically things are correct, and we need to aspect the functional aspect of the internal external genitalia and the HPO axis. So here I think you will be able to appreciate through the abdominal transducer, we are seeing the bladder, below which you can see a very flat, thin, small uterus, which is the prepubertal uterus, and a thin endometrial lining, which is the inner lining of the uterus. And here you can appreciate one ovary, which is very flat and very normal. And she seems to be developing polycystic ovaries on the other side. Okay, this is another other view where you can see the uterus transversely. Here again, you see the body and the fundus of the uterus, and you can beautifully appreciate how there is a 1:1 ratio. So this is the uterus and this is the cervix, which is of equal proportion in the prepubertal stage. So the other modes of investigation which I mentioned, where you do a MRI to find any pituitary tumors, any hypothalamic tumors, which is a very prompt diagnosis through an MRI, to do a wrist X-ray to check for the bone age of the child, whether it matches with the chronological age, to do a pelvic ultrasound to see if the ovary and the uterus are in place and are functioning. And this is an additional echocardiogram that is done in case of any congenital heart defects, which are also a part of things like Turner's, and they can in turn give us a diagnosis in cases of pubertal disorders. And you can see how they're slowly developing into a bigger and a more mature uterus with a bigger volume of ovaries, having some primary follicles, and there is, you can see one dominant follicle developing. You mean to say functionally also the ovary is producing follicles, and the uterus is also enlarging in size. So here again it is a prepubertal uterus, which is very flat, very thin, a very small endometrium, and very flattened ovaries with just few follicles. So this is one of an example of how a induction of puberty in case of delayed puberty, the regimen of hormone replacement that we can start with. The most commonly used drug is ethinyl estradiol, or we use estradiol also. So it can be either in the form of an oral drug, or it can be in the form of a matrix transdermal patch, which is more easier and compliant for the child. So for the child until 11, we don't really go for a high dosage. We just start with a 2 to 8 milligram dosage of ethinyl estradiol, and by 12 years, if we do not see any changes, then we start with a strong dosage of 10 micrograms of ethinyl estradiol, uh, 5 micrograms in case of oral, and as I mentioned earlier, 6.25 is the microgram of the estradiol patch that we commonly use. And we step it up as the age group increases. 13 years, we use 15 micrograms of ethinyl estradiol. Estradiol orally 7.5 micrograms. Patch 6.5 can be initiated up to 12.5. And 14 really needs that high amount of estradiol of unopposed estrogen. So 20 micrograms to start with, and 10 micrograms in case of oral tablets, and 12.5 to 18.8 micrograms in case of patches. So this is typically a picture of a precocious puberty child, where you can see there is stunting. There is still she is not attained the adult height, but you can see the adult breast development that is seen in her significantly. But still, there is no development of any pubic hair, or there is no growth spurt that is noted. So that concludes my topic for the day. Thank
Thank you,
you.
doctor. Thank you, doctor. Hi, doctor. The Q&A session is open. You can drop all your questions in the chat box. Dr. Pooja will be able to answer your question. Doctor, we have few questions in the chat box. I'll read it out for you.
Yeah, sure. Yeah.
Uh, can you share how much estrogen is started as the introduction and how it is gradually increased?
Yeah, that
How
was
we,
the last slide that was I was explaining how to
okay,
step up the regimen.
okay. And the next question, how to manage PCOS with hormonal treatment?
Okay, new topic for the day. PCOS hormonal treatment. So it depends upon what clinical spectrum they are presenting with. Do they have any hirsutism? Do they have irregular cycles? What are the primary symptoms that the PCOS patient is happening? So if it is only irregular cycles or oligomenorrhea or amenorrhea, then it is combined oral contraceptive pills. But in case if there is hirsutism or other androgenic effects, hair fall, all these male pattern balding, then anti-androgenic drugs also need to be included along with the uh, hormone replacement.
Okay. Um, thank. I am, doctors, I'm pasting the certificate link on the chat box. Please do click on the link and submit your query.
Thank you, sir. KP Singh.
Excellent presentation, Dr. KP. Thank you. I would request everyone to click on the link to submit the form. Once the form is submitted, you will get the certificates to your email ID. If not inbox, please do check on spam folder. If it's get delayed, the certificates will be delivered to you by tomorrow EOD. Any questions you can drop on the chat box. Dr. Pooja will be able to answer your questions.
Missed because of patience. I think you can access to the YouTube stream. Am I right?
Yes, yes, yes.
Yeah.
As we speak, this session is being live in the YouTube. Once the session is ended, the video will be available on the live section in our channel. Let me also drop you the links for our social media channel so that you can be keep in touch with us. There's been can follow us on social media. We have
Yeah.
planned a lot of webinars for the rest of the month. Please do follow us on social media to get the updates on all our upcoming webinars.
Any more questions?
I think the question I have again pasted the certificate registration form link on the chat box. Please do click on it to submit the form. If there are any questions, please do drop on the chat box. Dr. Pooja will be able to answer your questions. Doctor, I think the session was really good. I think there is no questions as such. Uh,
Okay.
yeah. Thank you, doctor. On behalf of all the doctors here, I would extend my heartfelt thanks to you for connecting at this hour and shedding the light on the particular topic. Thank you so much. And doctors, thank you so much for joining the session. We have a lot of webinars planned uh, ahead. Please do visit us on social media to stay updated. Thank you so much. Good night, all.
Thank you. Thank you so much.